Hello and welcome to Macomb on the Move. My guest on this lovely August day is Wanda Foster, Vice President for Nursing at McDonough District Hospital and Incident Commander for all that's going on around us. So how are you today?
Good morning, Gordy. I'm fine, thank you.
Busy.
It is busy.
I'll bet. I'm just going to open it up with kind of a broad-based question, and you can be specifics on the title with Incident Commander and what it is you do in that regard.
Well, with regard to Incident Command, it's sort of overseeing the entire COVID-19 response operation at the hospital. But I must say, in that role, there are section heads and chiefs that carry the weight of this.
Talk about that structure.
Sure. The key components of Incident Command are the Incident Commander, which is the one who's been delegated or designated to be in charge. But the key section chiefs under that would be Finance and Administration, which is our CFO, Bill Murdoch, Logistics, which is Peter Rao, Planning, Jordan Ball, and Operations and Tactics, which is Jimmy Rogers.
And this Rodriguez is, who's over the top? Who's over the whole, right below you in terms of running the show that used to be at the rec center at Western?
Edgar Rodriguez is our ESDA coordinator, and Lynette Kale from the health department was Incident Command. And we have kind of now stepped down somewhat from our area Incident Command, and we're more in a holding pattern at this point in time. But Incident Command, when you're under that function, it's a little bit like Legos. You can build them out as you need to, and then you can reduce down. And right now, we're more of in a monitoring state at this point.
What do you think is going to happen with the start of the school year at Western?
I want to be cautiously optimistic. I think right now is the time that we're really going to be put to the test as far as following social distancing, wearing our masks, hand washing, good respiratory hygiene. This is the time that is very pivotal for us if we're going to stay in a more controlled state.
Let's talk about that. We're not wearing our masks. That's evident. And we're 6 feet apart.
We are 6 feet apart. We have our masks close at hand, and if we were any closer than that in any type of setting, of course, our masks would be on.
I've asked this of Brian Dietz, I asked this of Ed Card, and I asked it of Jack McPherson, and later on this month I'm going to ask it of Rick Iverson. Masks and social distancing. Those are the two key pivotal things we all need to do?
We all need to do that. We need to do that for each other. We need to do that for ourselves. And hand washing, good hand hygiene. That's the third one. They are so important for us to get through this.
When I wear the mask, I don't wear it so much for Gordy Taylor. I would wear it if we were having a close interaction. I wear it for you.
Correct.
And people need to understand that. That's why. So why then do I see on Facebook people around town here getting together and got their arms around one another, people who I know and respect and think highly of, and they're having a great time, and they're not wearing the mask? What is that all about?
Well, I don't know that I have a good answer for that. I think that some people, I've heard them say, I'm over it. I'm done with this now. Like we've moved on. We haven't moved on. COVID-19 is here. There is no post-COVID.
Let me have you say that again, because I think that is so important, that there is no post-COVID.
There is no post-COVID.
Meaning what?
COVID is our new normal. COVID is here. And if you use as a comparison the Spanish flu that occurred in 1918, and it didn't end until 1920. 1918, by the way, is the same year that my dad was born. But that was a Spanish flu. And we have had over 100 years now to learn how to treat the flu, what to expect from the flu, how to get immunized from the flu, what to do when we have the flu. We have learned how to deal with influenza. We still have deaths every year across the country from the flu. We only have about half of our nation's population that take a flu vaccination, but we have learned how to deal with the flu. COVID is something we are all going to need to learn how to deal with. It is not going away. We hope to get beyond the pandemic, and we hope to manage it just as effectively as we've managed influenza. But we've known influenza for 100 years. We've known COVID-19 for less than 6 months.
Should we all still be getting the flu shot this fall?
Absolutely, absolutely. The flu shot is so important to protect your respiratory health, to not have excess admissions to the hospital, to not use our PPE, our personal protective equipment, for an illness that is very preventable or can be reduced greatly by the flu vaccine.
Let's go back to the fact that you say it's not going away. I am 74 years old. I had basic tongue cancer, meaning I had 35 chemo and 5 radiations. I've got some, Dr. Iverson has said that I have some chronic bronchial issues, and that's been concurred by some other folks. What does that mean for me?
People who are over 65, people who have had health illnesses, who have comorbidities, heart disease, diabetes, obesity, they perhaps are more prone to, or more susceptible perhaps of getting influenza or COVID-19.
So this is, again, it's not going away. Talk a little bit about, again, what the command center is all about. Is it for if something happens, boom, we can put people in, is it Bayless and Henninger? Where are you going to put folks if they need to be isolated? Well,
I think that if you're talking about the university.
Yes, ma'am.
The university, I believe, has plans in place to cohort individuals who need to be self-isolated. I can tell you from the hospital standpoint, which is the aspect of incident command of which I had responsibility for, not so much the larger community picture. We have 7 intensive care beds. We also used our senior behavioral health unit, which is open at this point in time, and it has been retooled in order to handle an additional 12 ventilated patients, should we need to do that. And then we have 3 other rooms, so we could manage over 20 ventilated patients should that need arise. Where we would need some assistance with that would be staffing and obtaining the additional ventilators to use should we need that.
Has anybody been put on a ventilator yet?
Well, yes. We have had a patient on the ventilator. We've had a patient on BiPAP. So far, we have had 13 patients at the hospital since March who have been COVID positive. We have had many, many more patients who have been COVID pending, meaning they have symptoms of COVID or we suspect that they have COVID, but their test has come back negative. We treat them as though they're COVID positive regarding wearing the full PPE, the full isolation, following all the procedures and precautions for the patient and for our staff.
We've had over 15 or 16 fatalities, but they haven't been people who have died at McDonough District Hospital, but they've rather died in nursing homes, correct?
Correct.
So they contracted this, but they never made it to the hospital to get care there. I mean, the hospital was there, but they just didn't get to the point
where
our
nursing homes have done a wonderful job in the care of patients with COVID. One in particular. And one of the things through this whole experience has been we have always had a good relationship with our nursing homes, and we have transferred patients back and forth, but we have never had the bond that we have with them now. And part of it, Incident Command through our logistics chief, which was Adrian McGregor, has been a bi-weekly call with all of our long-term care and congregate living facilities. And that has really, it's really forged some bonds that we hadn't had before. And I think that we've all been able to help one another through this time.
Are you looking for an uptick in this when fall comes? They had talked about back in March when I first visited with Brian Dietz about this, and by the way, a guy who's really, I think you said, laser focused.
Yes.
And I asked him, we were sitting there and we were in the cafeteria, and we were at opposite ends of that long table. And I looked at him and I go, why am I here, Brian? I'm going, we got 0 cases in McDonough County. Why am I here? Nothing's going to happen. Now he looks at me and he goes, it's coming. Trust me, it's coming. He said, I think it'll be here the end of April. Well, it turned out to be the end of May. What happened in that period of time? How did it get here?
Well, it didn't get here as fast as we thought it was going to because Illinois did flatten the curve somewhat so that it spread a little slower. But as people move about, as the weather became warmer, as we kind of left our community or people came to visit us in ours, it came to us. And we knew that was going to happen. As of August 20th, we have had 161 confirmed positive cases.
Now, and that's an interesting point, because those cases that are positive, if they're young people, they pretty much stay at home and get better, correct?
Correct.
What's the key? Is it hospital admissions and obviously deaths, but is it hospital admissions that really is the key factor here?
I think the key factor is our positivity rate, and that's what we really need to watch.
And what is that, please?
Our positivity rate for McDonough County, meaning the number of people tested versus the number who test positive, we are hovering just above 3%. And to be considered an area of warning, there are counties around us that are lighting up a little bit more, that are more warning. Their positivity rate would be around 8%.
Oh, my.
So right now, we are holding good at 3%. This is why it is vitally important as we have schools starting, as we have our university back in session, that we follow the guidelines that are before us.
So again, it goes back to the masks and the distancing. That's why our numbers are where they are. By and large, people are staying true to that.
Yes. And if someone feels that, if you think that you have COVID, if you are having symptoms, please get tested. We have a drive-through testing tent. It's located in the HSB parking lot just south of the hospital. And be tested. You don't need to pre-register and then go home and self-isolate. You need to stay home, take care of your symptoms, take ibuprofen, get plenty of rest, good nutrition.
I can attest that it's there. It's easy. It's quick. It's it's a little bit inconveniencing. Anytime somebody puts a Q-tip up your nose, I mean, that's not much fun. But that lasts all of a second maybe or 2 seconds. And I've been out there twice because I had a little surgery. But it really is not particularly invasive, and it's not. We don't have the lines that you have when you're looking at Houston and some of these other cities. That's just people are in line for hours. Here you're in and you're out.
We don't have the lines for hours, but we have about 46 cars per day, 46 people per day that go through our drive-through testing tent for COVID screening. And also on the news, you see the intensive care units and kind of the big hustle and bustle and people in the full PPE. We have never, of course, never had to that extent. Our staff are still wearing the same PPE that you see, but it's been very metered, it's been very controlled. That doesn't mean we don't give it the same level of concern. But right now, we are kind of holding our own.
But it's interesting, this gets complicated, does it not? Because we do what we're supposed to do, and then somebody goes to Florida or Arizona or wherever they go, and they go to a family reunion, and they don't wear the mask, and then they come back and they give it to Grandma and Grandpa, or anybody for that matter. And that's part of the problem, that people aren't doing this on a national level. I know,
right.
What about, to me, people who say, I have my rights, the Constitution says I don't have to wear a mask. That's absolutely correct. You have your rights. But in World War II, people had their rights, but we still rationed gasoline and food and nylon and rubber and all these things. And that's what we did to support our troops in World War II. That's what we did. We rationed. Fast forward to 2020, August 2020, and what we're being asked to do is to greatly inconvenience ourselves by wearing the mask that nobody likes,
Right.
but we know is necessary.
Yes, that's a great analogy.
So, I mean, and I think I ask Diane, my wife Diane mentioned the other day, she goes, you've had a couple of surgeries, right? And I go, absolutely. And she goes, what would you say to the doctor when they're putting you under if they're not wearing a mask? I say, get your damn mask on. You're going to perform surgery on me. She goes, well, isn't this the same thing? It's our little minor contribution to this effort.
It is. It absolutely is. And, the rule is we're supposed to wear a mask. We don't drive through town at 80 miles an hour. It's not safe. We could hurt someone. Wear your mask. It's not safe. You could hurt someone.
We didn't wear seatbelts.
We didn't?
You're
right.
When I was growing, I'll confess, I'm a bit older than you, but when we would go on vacation, we put this thing called a futon in the back seat of the car, and the kids laid back there and they slept and they played games, and there were 3 of them, and we're driving down the road at 70 miles an hour, and shame on us. But they'd have been rockets, but we didn't know any better, or we looked the other way. But when seatbelts became mandatory, it was time to wear the seatbelt, and we did.
And I think when we first went into COVID, initially, we weren't wearing, in late February, early March,
Right.
we weren't wearing masks. At that point in time, I think we were still a little distance. COVID was something that was over there. Pandemics didn't happen here in the United States, in Illinois, in McDonough County, in Macomb. It was something we'd see on the news, but it didn't happen here. This is happening here.
People are afraid to go to the emergency room. Should they be afraid to go to the emergency room if they need to?
No, absolutely. Please, if you need to come to the emergency room, if you need emergency care, by all means, you need to come to the emergency room. If you need to see your primary care physician, make that contact, reach out. Many of our physicians are using telehealth now. And I think one of the positives that has come from COVID has been we have been working on telehealth for a number of years, and it's had a slow start. It has exploded by light speed with COVID because we have been able to make those connections, to have the connectivity. Patients are very happy to be at home and connect with their doctor, with their physical therapist, and that is also a way to seek care. It doesn't replace in-person care, but it's a great way to seek care. But we certainly encourage you to come to the emergency room. We no longer are screening in our screening tent for emergency care. Anyone who comes to the hospital to be seen in the emergency room is taken directly back.
Explain telehealth. What does that mean?
Telehealth is when our physicians have a platform. We use DoxyMe, but there are many platforms you can use. And your physician or nurse practitioner, and we also used it with our physical therapist, can see the patient and converse with them real time. The patient would need to have either a computer with a camera or a smartphone or their iPad, and they're given a number similar to a Zoom call that they connect with, and they have their time one-on-one with their practitioner or provider.
Wow, the future is here.
It is here, and it's
Future.
exciting.
Future.
It's exciting.
You're busy. What is this all about? These incident command things. You have some reports to do.
We do. We went into incident command in March, and what you just put down is called our IOP, and it's our kind of our marching orders for each operational period that we had in incident command. And if I could just give a little background.
Please.
From a disaster preparedness, we had made the decision that it had been a while since we had in very in-depth incident command training, and in fact, I don't believe anyone on our senior team had gone through the full FEMA training, the NIMS training that we had scheduled. We had done some a number of years ago, and through attrition, those people were no longer at the hospital. And so in October, our incident command training was scheduled for the following March, which was 5 months away. About 3 weeks before that, we were saying, this really isn't a good time. We really don't have, we're in the middle of budget. We need to put this off. We really don't have time. And we gave a little pushback to Stephanie Kendrick, who did a wonderful job getting this set up for us. And she said, we really can't reschedule it. So we'll try to attend. We'll make as many of the meetings as we can, but we're very busy. Well, after about the first morning, it became very evident this is real, this is so important, and we're going to clear our schedules and make time for it. And during our incident command training, the example that our trainers, who were one was from Quincy, one Springfield, one the Chicago area, the example that they were going through with us each day was the tornado in Nashville. And that was what we were using as our model. Fast forward 10 days, and we found ourselves in Instant Command. And we were there from March 12th until the end of July. And we met twice a day, 7 days a week for a period of time, and then once a day. Then we went to 3 times a week, and then once a week. And then we closed out with the last month. And during these Instant Command report outs, we would zoom in with our EOC command that was at the rec center at Western. So it was very much a unified command and an amazing experience.
The Gulf of Mexico right now, is that what they're preparing? I mean, as this storm, as these two hurricanes come on land, they're prepared because they've done the same kind of things
Yes.
you guys have done in terms of preparation.
Exactly. In fact, I was watching on the news last night and I caught myself thinking, I wonder who's doing logistics and planning and Instant Command, because this is the same format that is used. One of the differences, though, is in most normal disasters, there's a beginning and an end. And we're finding ourselves, even though we are in a state of what's called demobilization, for us it's really hardwiring the safety practices that we have in place. We aren't demobilizing because we're still in the pandemic. When you have Instant Command for a natural disaster, it's usually a wildfire, tornado, ice storm, and you try to mitigate the disaster and help put things back to normal. Whereas we are still in the midst of the pandemic, and we're trying to hardwire all the safety precautions that what we have in place, our new processes, our new procedures, because we know they're here to stay.
Speak about hardwiring. What does hardwiring mean?
Hardwiring is holding the gain and just really making sure that we have permanent structures, permanent procedures in place. When we first went into Instant Command, and I've read in literature as COVID was coming up, it was kind of like building an airplane while you're flying. We were on the move and mobilizing quickly, and things were changing very rapidly. Recommendations were changing. We had new information. You worked the best with what you had at the time, and the next day the CDC or IDPH may have had additional information and would change that. We now know that drive-through testing, at the time we put up a tent and we started drive-through testing. We've made some changes on how we register people, on the hours of day. We know that going into the winter, a tent may not be the best place. We may need a more permanent structure for this. So we're putting plans in place so that we can keep our patients safe and our staff safe all year long, no matter the season, because we know people don't want to come into the hospital always for these tests.
In terms of budgeting, this has just created absolute chaos, I assume, for your budget folks at the hospital as you're trying to deal with this whole new, huge dimension of our lives.
Yes, it very much has. In April, when we stopped our elective cases and surgery, we have really prided ourselves as hospital industry overall of providing outpatient care. And in April, hospitals across the United States had to pull back on the very services that were our bread and butter. Now, and we did not experience the inpatient rise, which is wonderful, but that means that we were very low on the services we provided for quite a period of time, which caused us to have furloughs, some layoffs, which are very, very difficult to do. We are having volume come back. We are having staff come back.
And people who are reluctant to go to the hospital, it shouldn't be, because it's the safest place to go. When I have gone out there to meet with you or with Brian, I mean, I get my temperature taken. They make sure that I'm okay, and everybody's wearing a mask in the hospital. When I was at the Springfield Clinic to have my surgery, I mean, boy, I tell you what, they're making sure that everybody is safe before they let you in.
We are. We check temperatures. We always ask about symptoms. We do screening. You had mentioned earlier the financial aspect. Typically we would do our budget for a 12-month period of time. Our fiscal year started July 1st, and we're doing a 4-month budget to see where we are and then reassess for the rest of the year, because things are changing so rapidly and there are so many unknowns. we felt that we could not in good conscience plan for a 12-month budget. We needed to really evaluate what these next 4 months would be like.
Do we anticipate a surge at some time in the fall, or do we know? I mean, we're so conscious in this area, and you said that 3% rate, which is marvelous, but the governor has been very cautious about opening things up and so forth. Do we anticipate that we're going to get a huge surge? Are we going to have like a New York or something like that, or are we?
We do. We do anticipate a surge. It won't be like New York, I don't believe. Last spring, when we had higher cases, and the majority of those were able to stay out of the hospital, it has been projected that COVID will have 3 waves until we have a vaccine available to us. The second wave, predictably, you would expect to be greater than the first wave, and then there will perhaps be a third one beyond that. And it's just the unknowns. It's the unknowns of how well people will social distance, how well they will wear their masks, and that you stay home and self-isolate if you have symptoms. And that's very difficult sometimes. While it seems easy to do, I've heard people, as they've been screening, as they're coming through the tent, and we treat everyone with a great deal of empathy, is always our goal. We've had people say, I'm hesitant to be screened because I don't feel like I can miss work. And these are people who are in our community, not, and they may have a loved one going into the emergency room. And if their loved one is going in with COVID symptoms, we don't allow anyone to go with them unless it's a child or special needs. And we have people that are hesitant. They feel that they have been out of work for a long period of time. They're finally going back to work. And those are the ones we really need to help. You need to stay home for yourself, for your family, for our community.
What will bring the second and third wave? What makes that happen? Why doesn't this thing just go through and then we're dealing with it for the rest of our lives? Why do we have this next wave coming in? Why does that happen?
Again, we're still learning about COVID at this time. We've had the summer months where we've been outside. People haven't maybe wanted to be inside as much. We're getting ready to have smaller groups in classrooms again, and that's going to bring it back.
Katrina, 15 years ago, was FEMA not ready for that? Is that what happened there? Of course, it was catastrophic with the amount of water that they had to deal with and so forth, and wind. But I assume FEMA has gotten much more sophisticated since that time, and since that was such a huge disaster.
Yes, I'm sure that they have. And in fact, Katrina, in part of our FEMA training with Instant Command, Katrina is used as an example many times. That's sort of the placeholder that kind of resonates with everyone.
So flexibility is the order of the day, change is the order of the day, and every day is a new day. But this is certainly complicated everybody's life out at the hospital and in the community. But we just have to take it day by day and wear the mask.
Right. Yes, we have never had this much disruption in healthcare ever. It has just totally turned our world upside down. So
worst case scenario, this comes back huge. It's possible that we end up stopping elective surgeries, and all those things could happen again if we're not vigilant.
Right. We certainly hope not. We are doing, now that we've been through this once, I think we're a little more prepared. We know our turnaround times for getting our swabs back, our nasal swabs back. We have put in place, the primary reason for stopping elective surgery was to preserve our PPE, our personal protective equipment. And we have put a very strong stewardship plan in place to preserve our PPE, and we have a good supply of that now, and we use it very diligently on exactly when it should be used, and I think that we're ready for a stronger inpatient census than perhaps we would have been before.
So you're ready for whatever comes our way?
We are.
Good. Well, let's move on to Vice President of Nursing. What does that person do?
Well, that person, I guess, oversees or has responsibility for all the nursing departments of the hospital, as well as some other departments of that, pharmacy, cardiopulmonary, radiology, physical therapy, laboratory, home health, hospice.
So you're a busy girl.
I work with a wonderful staff, and they're an amazing team, and they're the ones who are on the front line of this.
Let's talk about your biography a little bit. To talk about your mom and dad. They're farm folks, right?
They were. My dad was a farmer his entire life in McDonough County. My mother moved here to work at Western Illinois University in 1950. She didn't care for Macomb, didn't care for the topography. It was too flat. She was going to move back to her home in Kentucky, and then met my dad at church.
And what life lessons did you learn from your mom and dad?
Strong work ethic. They were very loving, caring people. We lived on a farm. We had our own produce, our own livestock. They just cherished the simple things in life.
And you were an only child, correct?
I am. I still am.
So as an only child in a farm family, you got to learn a lot about chores and working in the field and doing all kinds of things that used to be reserved for the guy.
I did. I could hold my own with sorting cattle and things like that.
So high school, where was high school?
I attended Industry High School.
Back then, the Eagles?
The Industry Eagles, yes.
And what'd you do in high school? Were you in any sports or any community kind of stuff or band or anything like that? What'd you do? Anything?
Sure, I was in marching band. I did play volleyball and softball. Of course, always careful not to break a nail, so I maybe wasn't the best player in that. I was in 4-H.
Were you involved with prom?
I attended prom.
Were you the prom queen?
I was the prom queen.
So
yes.
So if you're the prom queen, there's got to be a prom king, and who would that prom king be?
As memory serves, I believe Steve Onion.
Steve
the
Onion.
prom king.
Kathy Chenoweth's husband. Yeah, Kathy worked with me for 14 years and was a great asset at Western. And Steve, he and Steve Churstrup are very, very aggressive farmers. Been out there a long time.
In fact, Austin Farm's our family farm.
Oh, Austin, yeah, young Austin. So you graduate from high school, you end up at Bradley. How'd you end up at Bradley?
At the time when I graduated from high school, Bradley was the closest baccalaureate nursing program to Macomb. And my father had recently passed away, and so I had initially planned on going out of state, and so instead chose Bradley.
Why'd you get into medicine? What was it about that? What happened in your life that made you decide this was what you wanted to do?
When I was growing up in the 60s, my grandmother lived with us and needed quite a bit of medical care, and so our family physician stopped by our house on the way from Industry to Macomb, usually once a week on Thursday morning, and I wasn't in kindergarten yet, and so I would go out and greet him and go in and be his nurse and wear my JCPenney nursing uniform, and I imagine that may be how that started.
And who was that doctor?
That was Dr. Andrinovics.
How about that?
Yes.
So you come back, and then when you graduate from Bradley, what happens?
I graduated from Bradley, and I had a job, or was hired at McDonough District Hospital, and then I did get to round with Dr. Andrinovics to see his patients, but I worked on acute care, the intensive care unit.
Let's go through acute care, intensive care.
House supervisor, home health, hospice as the director, and then we formed outreach services, and then vice president of nursing.
Wow.
And I should add, when I was at Bradley, I did work as a nurse's aide at the hospital. That was my starting point when I came back for summer breaks and Christmas.
So we talk about hospice, and Marcia Caslett McGrew was involved with that for many, many years. What's the difference between hospice and palliative care?
Palliative care is providing comfort at the end of life, comfort rather than cure. And hospice care is an element of palliative care, but with hospice care, in our MDH hospice, it's not a physical place, but it's also a type of palliative care, but it's presented to you by a team. We have our hospice medical director, we have nurses, home health aides who care for the patient, we have a volunteer component, And we hope that patients can stay in hospice care. To qualify for hospice, you have a prognosis of 6 months or less if the disease runs its normal course. It's not something where you come in for the last week of someone's life, ideally. We like to have that time to really help patients and families adjust and to be very mindful of this very poignant time that they have.
So you mentioned 2004, a wonderful man named Steve Hopper says we need a vice president for nursing, and you're the person.
Yes.
And it changes your life, I assume, forever. Or you wouldn't be doing this incident command, all this stuff.
In fact, when we went into incident command, Steve had sent a note about, remember when we used to wear our vests? We would have disaster drills at the hospital, and you would choose people to be different positions of incident command. We wore a vest that would say operations or planning, and we had a good laugh about that, but never dreaming. Most disaster drills we have would last 4 to 6 hours.
Let's talk about our part-time, our interim director, Brian Dietz, shows up. Talk a little bit about Brian. He's quite a guy. He's a hard-charging guy.
He is. Brian has a wealth of experience from working in hospitals across the country. And I think that's one of the greatest assets that he brings to us. Many of us, myself included, have grown up working at McDonough District Hospital. And so it's been very important that we stay current with our field, with the industry, with what's going on around us, both in the state and nationally. And Brian has worked in a variety of places. And he is excellent at managing data and decision-making. And he definitely has the big picture view for us.
Is the Women's Center up and running?
The Women's Center is up and running. It is. OB is completely finished and looks beautiful, very functional, a wonderful center of excellence for our patients. On the radiology side of the Women's Center, we are still finishing up some work. That work was slowed down during the time that we went into our COVID measures because we didn't bring any outside contractors into the building. And so that slowed our completion a bit, but it's nearly finished on the radiology side too.
We're very fortunate to have McDonough District Hospital in our community, I assume.
We are, yes.
Very, very good. Hey, talk a little bit about yourself. If you could have dinner with some famous person, who would it be, or who would it have been?
I think it would be Walter Cronkite. Growing up, he was always kind of like our window to the world. And I think the first national event I remember would be President Kennedy's funeral, and just his compassion. And then all the Apollo years, and at the Cape, and the space flights. You know, he was the one who kind of brought the world home to us.
And when we watched Walter Cronkite or Huntley and Brinkley or John Chancellor or whoever it was on ABC, when we watched those all men at the time, and they did their half hour, that was the news.
That was the
and we thought that was very objective, what they were telling us, that we, you know, and if I remember clearly, a bit older than you, but when Eric Severide would come on CBS after Cronkite had given the news, he would say, "I'm Eric Severide, and now I'm going to do an editorial," and you would know that an editorial was coming. He was going to give his view of the world. And today it's gotten so much more complex because when you watch the news, you can watch whatever kind of news you want to watch without getting into politics. But it's a very different world from when we had those anchors so many years ago.
It is very different.
Very different. Okay, I got to ask you, how about a favorite movie?
I love The Big Chill. Great music.
Great, absolutely, absolutely great music. Yeah, and we had
Fun movie.
Yeah, all of us we would have big chill, parties and so forth without anybody dying.
Oh, of course, right. Yeah.
But the cooking and all that, and people walking around with wine. Those are great. That's a great choice. What do you do for fun?
For fun, I love bicycling. I love photography, like walking, reading.
What's the best advice you ever got?
Work hard, enjoy family, enjoy the moment.
Somewhere you had said something to me about adversity. Adversity
Adversity doesn't build character, it reveals it.
Elaborate a little bit.
I think in this period of time, we are under so much constant and stress, level of anxiety, what's going to happen. And I think it's just very important that we focus on resilience and that we can get through this pandemic. We know that COVID will be here, but we can get through this pandemic. There will be a vaccine, and we're going to make it. But we all have to stay the course. No one can just be over it. We have to do it together. We have to social distance, wear our masks, wash our hands. But we are who we are on the inside, and it's important that we show kindness and patience, and we can come through this together okay.
Talk about the vaccine. Will it be a vaccine or vaccines? What will it be, or do we know?
We don't know. We don't know. There are several clinical trials that we hear about, that we read about, and one thing that resonated that I read a while back that I thought was very interesting is the FDA will be very, I've heard people say, well, when the vaccine comes out, I will want to wait to take it. And even though people are hurrying, trying to create a vaccine, of getting the funding resources to work on a vaccine, the FDA, I have great trust, will not in any way compromise testing or will not compromise the efficacy of the vaccine just to get something out. When we have a vaccine, I trust it will be very safe and something for us to take. And I don't believe anything will be short-circuited or shortcut in order to have something fast.
Why would I be reluctant to get the vaccine when it becomes available? Because I think I'm going to get COVID by taking the vaccine?
I would hope not, but I think some people are thinking that maybe things are being rushed. And I don't know that. I'm going to take the vaccine also.
I'll be first in line, yeah.
Yes, I'll be right behind you.
I was joking with Ed Card about it when I interviewed Ed, and I said, so I've got, I'm 74, I've had this bronchial stuff, I've had cancer. He goes, you'll be first in line. Come on in. So yeah, I'll be there. You've got a couple of sons. Talk about them a little bit.
I do. I have a son who is in California, who is a financial advisor, and then I have a son who is in Grand Rapids, Michigan. He's in a second-year residency in internal medicine and pediatrics.
Have you been able to see either one of them since all this happened?
I have not.
That's tough.
It is hard. It's very hard.
That is, yeah. It's just, any grandchildren?
Not yet.
Yeah.
Almost.
As somebody, oh, really? Would do when?
October.
Then what, Grandma? How will that? It's going to be, maybe things will open up a little bit, but that's hard.
It's hard.
That's what Diane and I find. We have 3 kids, but one's in Corpus Christi, Texas, one's in Cleveland, and one's in Chicago suburbs. And it's hard not to see them, but it's also hard not to see the 6 grandchildren that go along because, someone said to us the other day, this is hard because we're at those of us that are a little bit older, the tick-tock, time's marching. And these kids are growing up and we're missing out on part of their lives, and that's difficult.
Right. It is difficult. And knowing that we all want to keep each other safe, and that just has to be the prevailing measure of this.
You've been on the industry school board. You've done some development work with the hospital, some community relations, Red Cross. But you're very proud of your work with Athen. What is that?
Athen was the American Thrombosis and Hemostasis Network, and it started in, I guess, the early 2000s. And we did a lot of work with patients and families with bleeding and clotting disorders. And in fact, Katrina was one of the reasons that we put together a project to help those with especially bleeding disorders be able to seek care if they were displaced from their hemophilia treatment centers. And we had people at that time in Katrina that some went to Houston, some went to other states in the area, but they didn't have access to their medical records because our records weren't computerized then. So we worked very hard in a way that people could take their medical records with them, unlike a credit card kind of chip design. Now we have electronic medical record. I'm no longer on the Ethan board, but it's still very vibrant, and it's working on, it funds many research projects for both bleeding and clotting disorders.
What do you think is the future for McDonough District Hospital on one hand and healthcare on the other?
McDonough District Hospital is looking at critical access potentially in the future. Should that window open for us, we think that would be very advantageous for us to take advantage of this.
What does that mean?
We would still be a very strong hospital. We perhaps would not have as many beds. Right now, we are licensed for 48 beds. Critical access would have 25. Typically, our census, we seldom hit 20. Perhaps flu season, we may get into the low 20s. Now, for COVID, there's always exceptions that are made that we could surge up should that be needed. But in a traditional world, a critical access hospital would have 25 beds, very vibrant outpatient program, just as we have. You wouldn't see any difference there. But where it would be most beneficial to us is how we would be reimbursed from Medicare.
What do you think will happen with the future of medicine? What's going to happen there? Are we going to have more of the telecommunication?
I think we will have a lot more telehealth, telemedicine available to us. You know, there's tele-intensive cares that people can consult in intensive care units. We do not have a great length of specialists in Macomb, whereas if you go to a larger tertiary care center, there are ologists for many different things. Telehealth or telemedicine will allow us to bring that to us. We have the capability to do that. We have worked with SIU in Springfield several years ago, and it just was a little slow taking off. But I think that we certainly have a need again to revisit telehealth. We also have a strong working relationship with Blessing Hospital.
What's that all about? I saw it in the paper that we're now associated with Blessing Hospital.
Yes.
What does that mean? That we get access to their staff?
Yes, we have a collaboration agreement with Blessing that we will work together on bringing care that Blessing can bring to McDonough County, to McDonough District Hospital. Our two biggest success stories have been Blessing Cardiology. We have cardiologists here 3 days a week, and we are hoping that that will grow in the future to a full-time cardiologist. We have pulmonology that is here at least twice a month, sometimes more. And we really appreciate the philosophy of bringing a physician here and being able to see patients in our community and use our supporting services such as stress tests, lab work, procedures, to do them here as opposed to asking patients to see them and then drive to Quincy or to drive somewhere else for their care.
And we didn't have this before.
We have always had cardiology, whether it be from Springfield or from the Peoria area. We did not have this much. We did not have the consistency of 3 cardiologists, 3 physicians here every week.
What's going on with the outside of the hospital with this, all the stuff that Brian's got out there? And were you part of that? Was there a picture of you or something on there, up there? In some context? Somebody mentioned that to me.
There was, and there's a great picture now of our ER nurses that are on that wall, and it looks wonderful there.
It's just kind of inspiring.
It is inspiring, and I really like pictures of our staff and of our medical community, and we have more plans for that wall because we didn't realize how many cars go by that side of the hospital. And I think it's a great way to recognize our staff. And yes, we do have some banners and some flags, and it's just really to show that sense of community and that we are all in this together.
You're vice president and involved with this virus in a very open way and pronounced way. What's your leadership style?
My leadership style, I very much want to support my staff, and I want them to have the resources and the expertise they need to do a phenomenal job. I like to lead with empathy, and I'm very cognizant that patients can choose to go anywhere, and I very much appreciate and respect, and I'm very sincere that they choose to come to McDonough District Hospital. I know in the emergency room, there are patients that are going to be there later today that don't know that life is going to deal them a bad hand. And today's the day that they're going to mark on their calendar of when fill in the blank happened. And so I think it's important that we're all prepared to meet people where they are and to treat them with care and concern. Everyone's scared, and we want to be there for them.
To a different degree, everybody's, if they're not scared, they're concerned.
They are.
Or they should be.
Yes.
Yeah. Well, you're obviously a very empathetic person. What frustrates you? What gets under your skin?
I guess when people, if you're regarding COVID,
Anything.
if they just don't care, yeah, that's someone else's problem. If they just have a lack of disregard for humans, for healthcare, for taking care of one another. We all just need to keep that mindfulness.
Other than family, what are you proudest of?
What am I proudest of? You know, I think I'm proud of the work I've done with Athen, but I think I'm also very proud of where our hospital has come in the past 40 years that I've been there. I think we have grown in so many ways. We provide so many new and different modalities, and in some small way, if I've had a part in helping bring these services here, helping design a new program, I'm proud of that.
Any interesting stories about COVID and any incidents that have happened that stayed with you?
I think our communities, we have a very caring community, and we have had people stop and just drop off, early on, would drop off PPE supplies, the homemade masks that were made for us and brought to us, the people who painted decorative rocks and put them out, the individuals who have purchased meals from local restaurants and say, I would like for 20 people on the front line, whoever you feel they are needed. We've tried to share those with our nursing home partners as well, but the generosity, I know we focus on wearing masks and things like that, but there's been so much generosity from our community of just coming together.
What do you hope your legacy will be when you're done working? When you walk out the door, what are you hoping they'll say about Wanda Foster?
I hope that Lisa, that I cared, that I was there for our patients, for our staff. I'm excited where nursing is going in the future. I'm excited for, I guess, for our new nurses coming on, because they are joining. We have a very strong group of younger nurses right now. And I was actually just talking with our house supervisor this morning, and she was saying what a great job they're doing in OB and then the intensive care unit and acute care. And they are becoming nurses in a time that we have never experienced. And these are nurses who are coming in full PPE and going home and taking care of their own families and not knowing how school's going to be. And I'm very proud of them. I know we'll be leaving it in good hands.
These are challenging times. Are you having any fun?
Yes. You know, we work with a great group of people, and it's our staff and again, their resilience. In fact, today I was walking into work, and a coworker who actually works in one of the clinics rolled her window down. She goes, "Happy Monday, Wanda." You know, I mean, the spirit
It's a positive
and the
attitude.
kindredship,
Yeah.
it's all there. Because again, you know, as I said, adversity doesn't build character, it reveals it.
You mentioned, we talked about Western a little bit earlier and the school year starting up. What sort of a relationship do you have with Western in terms of interacting through all this?
For myself personally, I have not had quite as much. However, there is a Western representative on our weekly calls that we have with the health department. And it's the health department. We have community leaders and someone from the university is on that, and the ESDA center. But I think that Dr. Card, our CMO, and Patrick Osterman, Adrian McGregor, I think there has continued to be a working relationship with Western, and we've tried to stay in concert with one another.
You folks have built, Steve Hopper, now Brian, but you've built quite a team, haven't you?
We have.
You'd like to keep that, I assume you'd like to keep that team together. It really seems to be very cohesive. It seems like everybody's supporting everybody's got a smile on their face. Everybody is tremendously cooperative.
Yes.
As we've been through these series of interviews with medical professionals, yourself, Dr. Card, Dr. McPherson, Brian earlier, and soon Rick Iverson. They just seem to be a group that really cares about one another and the community.
We have never had a stronger team, nor have we ever had to face what we've been up against. And I think that has really helped build those bonds. Dr. Iverson has attended nearly every incident command report out that we've had. We've had a few other board members that also attended, but he by far has been at so many, and many times he would provide some words of wisdom or of encouragement or support as only Dr. Iverson can do. And he would do that at the end of our incident command. And it just, it was just very nice for our group to hear.
Wonderful man, and you're fortunate to have him as your board chair now.
Absolutely.
Yeah.
Absolutely.
Well, anything else, Wanda? Maybe some parting thoughts on to the community on COVID and what we can do to deal with it best.
Follow the guidelines as we've spoken. Stay positive. Stay home as much as you can. Follow the rules. Wear your mask. Smile with your eyes. Be patient. Be kind.
I like to smile with your eyes because sometimes you can't tell who's behind the mask. So that's a nice way of getting
Sometimes
to stay
it's
in
hard
touch.
to tell even at a meeting who's speaking.
Yeah.
But we're in this together. We can do it.
And we have to do it.
We have to do it.
Wanda Foster, thank you so very, very much for taking time from your schedule to be here. I know you've got a lot to do, and I appreciate you coming by. And to you folks, thanks for joining us on this segment of Macomb on the Move. We'll see you around town. Don't forget to wear that mask and keep that social distancing. Thanks for watching. Take care.